Hello, I'm Dr. Tedesco D.O, Co-Associate Program Director of Good Samaritan Regional Medical Center's Orthopedic Surgery Residency in Corvallis, Oregon. Today I'll be lecturing on malignant soft tissue tumors, or soft tissue sarcomas essentially, as part of our ongoing online lecture series to supplement our case-based in-classroom learning. My disclosures are up to date and public at the AAOS website. First, we'll begin with just some general information about soft tissue sarcomas. We'll start with the epidemiology. There's about 10,000 new cases of soft tissue sarcoma per year in the United States, which accounts for about 3,800 deaths. There's a 73% 10-year overall survival and a 93% local control rate at 10 years for the vast majority of soft tissue sarcomas. 5-year survival rate is based relatively on tumor size, where the smaller the tumor, the better the prognosis, with a 90% 5-year survival with small tumors between 0 and 5 centimeters, and only a 44% 5-year survival when the tumor is greater than 20 centimeters. The thigh is the most common site where soft tissue sarcomas show up, and the anterior compartment is the most common. The sartorius is a debatable part of the anterior compartment due to a separate fascial envelope, but can be involved with sarcoma as well. Surgery and radiation yield 90+% 5-year local control rates. Radiation-induced femur fracture is most common when the anterior compartment of the thigh is involved. Edema is the most common in the medial compartment where the lymphatics reside, and nerve damage is the most common in the posterior compartment where the sciatic nerve is after radiation therapy. In terms of soft tissue masses, any soft tissue mass is concerning for sarcoma if it's greater than 5 centimeters in size, deep to the investing muscular fascia, heterogeneous on the MRI, exhibits rapid growth, or is very firm to palpation. In terms of grading soft tissue sarcomas, the World Health Organization currently recognizes close to 70 histologic subtypes, and they're classified as low, intermediate, and high grade. Low grade are well differentiated with minimal pleomorphism and mitoses, and a high grade is undifferentiated with extensive pleomorphism, anaplasia, and multiple mitotic figures. The most common soft tissue sarcomas by age are rhabdomyosarcoma in kids and adolescents, synovial sarcoma in young adults, liposarcoma in middle-aged adults, and undifferentiated pleomorphic sarcoma in older age adults and the elderly. There's a mnemonic for soft tissue sarcomas with lymph node and bone metastases propensity, and that is race or care. Only about 8% of all soft tissue sarcomas overall metastasize to lymph nodes, but these particular sarcomas do it at a much larger rate. Those include rhabdomyosarcoma, alveolar soft part sarcoma, angiosarcoma, and adamantinoma as the A's, clear cell sarcoma, and epithelioid sarcoma. Synovial sarcoma used to be in this, and it used to be scare or races, but several studies have now demonstrated that synovial sarcoma does not, in fact, have any greater lymph node or bone metastatic potential compared to the majority of other soft tissue sarcomas. In terms of general sarcoma treatment, low-grade histology generally gets surgery only, while high-grade gets both surgery and radiation therapy, either in the adjuvant or neoadjuvant setting. If radiation therapy is given preoperatively, there is a much higher rate of wound dehiscence, and if it's given postoperatively, you usually have to wait until the wound has completely healed to begin, so usually around 2 to 3 weeks postoperatively. You want to avoid circumferential radiation to an extremity to minimize vascular and lymphatic damage, and Bill Enneking was always quoted as saying, "Radiation therapy is not a substitution for bad surgery." So in general, if there's a grossly positive margin or extensive positive margins, radiation therapy is not enough to clean that up. That needs more and better surgery. If you have a focal positive microscopic margin on a critical structure that would otherwise have to be sacrificed, which usually means an amputation, then it may be reasonable to consider radiation therapy with the understanding that those patients are still likely to have a higher rate of local recurrence. The greatest benefit with radiation therapy is seen in myxoid liposarcoma, vascular sarcomas, and myxofibrosarcoma, all of which tend to be exquisitely radiosensitive. Radiation alone is generally reserved only for unresectable disease or massive recurrent disease in the setting of metastatic disease. Therefore, in general, it's not used with curative intent. It's extremely high dosing, so the rate of complications is also very high. Almost all soft tissue sarcomas, with the exception of the smaller low-grade tumors, will get radiation therapy, but chemotherapy is historically reserved for younger patients with good prognosis, but a high-grade lesion that's very large, usually greater than 8 to 10 centimeters. There's only about a 4% benefit to overall survival, with a myriad of serious chemotherapy-related toxicities and complications as a result, and that's why it tends to be reserved for special indications. In terms of radiation therapy, when it's used, it can be used before or after surgery. Before surgery tends to get a lower dose, although there's ongoing studies with postoperative radiation using the exact same dose, and so far early results are yielding similar to the old way of doing it with a much higher dose postoperatively. When you do it preoperatively, a smaller area needs to be radiated because you can visualize the tumor directly under imaging and therefore can get close to the margins, and it's better used for anticipated close margins where you're trying to get the tumor away from a critical structure. It's also better for low-grade tumors that are greater than 5 centimeters or high-grade tumors, but there's a much higher rate of wound complications with patients given preoperative radiation. You usually need to wait somewhere between 3 and 6 weeks after the last dose of radiation before surgery to minimize this risk, to allow the skin to heal and recover from the radiation before cutting into it. These wound complications can be serious and devastating. They can be deadly because the healing potential and the immune system in the area are very weak and poor after radiation. I've had a few patients that basically never healed, where they continued to have open wounds 3 and 4 years after surgery. Postoperative radiation, as we said before, tends to be a higher dose, but hopefully future studies will lower that dose. This is done once the wound has completely healed, and it's easy for good margins when you know there were no critical structures and you were well around the tumor. But a greater area needs to be irradiated, and as a result, there's a higher incidence of long-term effects like fibrosis, arthrofibrosis, adhesions, and edema. This is useful for positive margins, as we talked about before, when there's a focal positive margin on a critical structure. If there was a whoop surgery performed, then you're already in the postoperative setting, or for extensive or massive lesions. If you're going to do postoperative radiation, after you remove the sarcoma intraoperatively, you want to place metallic vascular hemoclips throughout the tumor bed for the radiation oncologist to be able to visualize these under imaging to determine the treatment region that needs to be done to try and minimize that collateral damage. 45 to 50 gray is usually the maximum allowable dose for retroperitoneal sarcomas, which is lower than the doses above. So you can see that it tends not to be as effective, and the reason we are limited is because of the proximity to vital structures such as bowel and the high degree of toxicity when those structures get radiated. Radiation-induced complications include wound complications, as we talked about before, edema, arthrofibrosis, adhesions, skin burns, fracture, including up to a 30% chance at 5 years if the periosteum is stripped at the time of surgery, and viscera damage, especially for truncal and retroperitoneal sarcomas. A radiation-induced sarcoma is a separate entity that is a new sarcoma within a previously irradiated field for another tumor, whether it was a sarcoma or a carcinoma, most commonly breast cancer. This is a rare phenomenon, only in about 0.6% incidence in the previously irradiated field. Bone sarcomas tend to be much more common that are radiation-induced than soft tissue, but soft tissue sarcomas tend to portend worse survivals and outcomes. Treatment usually involves everything you can throw at it because these are bad actors and they tend to be highly resistant to conventional chemotherapy and radiation, and so they will get surgery and chemotherapy plus or minus more radiation depending on the previous dose to that area as well as the prognosis of the patient. The criteria to diagnose a radiation-induced sarcoma include that the histology has to be different from the original lesion, otherwise it's likely a local recurrence rather than a radiation-induced lesion. The development of the sarcoma must occur in the radiation field, not nearby it, and the Rizzoli Institute found that there was a mean 33 gray needed to create these, so they tend to be much more common in previously irradiated tumors rather than radiation for other reasons such as heterotopic ossification. There needs to be an adequate latent period from the radiation therapy to sarcoma development, otherwise it could just be a separate sarcoma within that area. This is somewhat debatable as far as what constitutes a latent period, with some authors advocating for 2 years, others 3, 5 years, but it has to be a significant amount of time, and this can occur out to 20 to 25 years after radiation. Additionally, the patient can't have any tumor syndromes that are known to create multiple sarcomas throughout their lifetime, such as Li-Fraumeni. Now we'll move on to the specific soft tissue sarcomas and soft tissue lesions. We'll start with the atypical lipomatous tumors. These used to be called the well-differentiated or low-grade liposarcoma, but they've been reclassified by the World Health Organization because in and of themselves, they do not have an ability to metastasize. However, they do have a tendency to de-differentiate into a high-grade spindle cell sarcoma that then can readily metastasize. So these lie somewhere between benign and malignant. They need to be excised because of their degenerative potential. Unlike a lipoma that often can be just observed, there's a higher risk of local recurrence with these than a conventional lipoma because they tend to be more infiltrative and they're very difficult intraoperatively to distinguish a clean margin from the surrounding normal fat. Additionally, they just tend to be more aggressive in general than a lipoma. The current treatment recommendations for these are a marginal excision just like a lipoma to start with, but if they ever recur, that's where the risk of de-differentiation is the highest, and that typically warrants then a wide resection. On imaging, these quite often have a much more infiltrative and lobular appearance than a typical lipoma. They also tend to be this quote-unquote dirty fat where they're a little bit grayer, they have more stranding and increased heterogeneity within it. However, many of these findings have been debunked in multiple studies where they're not pathognomonic. And so unfortunately, those sorts of findings could still be a benign lipoma, and typical benign lipoma findings could still be an atypical lipomatous tumor. So histology is key to making this diagnosis. In terms of the other liposarcomas, this is a very common sarcoma and represents 1/3 of all soft tissue sarcomas in adults. It's the most common soft tissue sarcoma in the extremities, followed by undifferentiated pleomorphic sarcoma. Leiomyosarcoma is actually the most common overall soft tissue sarcoma, but it tends to be most commonly surrounding abdominal organs such as the uterus and retroperitoneal vessels, which is why it's not as commonly presenting to orthopedic oncologists. It tends to be a disease of middle-aged adults, with males getting it at a greater rate than females. The thigh is the most common area, as well as the retroperitoneum, and rarely you can actually have a primary liposarcoma of bone. Prognosis depends a lot on the grade and the specific type of liposarcoma. A well-differentiated liposarcoma exhibits less than 10% local recurrence rates and a less than 1% chance of metastasis with almost 100% overall survival, whereas intermediate and high-grade liposarcomas, even with appropriate treatment, tend to have a 20% risk of local recurrence and a 5-year survival between only 20 and 50%. The myxoid subtype characteristically metastasizes to the retroperitoneum, followed by intra-abdominal extrahepatic sites, followed by the lung. It's the only soft tissue sarcoma without a predilection for lung metastases. In terms of imaging, again, a lot of it depends on the type of liposarcoma. X-rays may show calcifications or even heterotopic ossification within the lesion itself, especially in well-differentiated tumors. These are often differentiated from lipomas on MRI by thicker septations, enhancement with contrast, whereas a lipoma usually will not, or significant heterogeneity on the sequences. If it's well differentiated, it will suppress on the fat-saturated T2 images, which make it difficult to tell the difference between that and a lipoma. But de-differentiated, like in the images seen below here, will have a large, benign-appearing fatty tumor like there is in the anterior compartment of that thigh, but then a region of non-lipomatous tissue. So that's that low signal on the T1 on the left and the higher signal on the T2s on the right. That's the area of de-differentiation that no longer saturates with fat suppression. The myxoid subtype also will not suppress on a T2 that has fat suppression because of the myxoid component, tends to hold on to a lot of water, and it stays bright as a result on the fluid-sensitive sequences. In terms of histology, again, this is dependent on the type of liposarcoma. The conventional liposarcoma tends to be a mixture of mature fat cells of variable size with interspersed lipoblasts throughout the imaging, with a fibrous background and fishnet blood vessel-like proliferation and pycnotic nuclei. It's S100 positive, and the lipid granules will stain on an oil red O stain, which help differentiate this from other clear cell sarcomas. The atypical lipomatous tumor will have a ring chromosome 12 with MDM2 and CDK4 gene amplification, which is what differentiates it from a lipoma, because histologically they can look very similar, even though these tend to have more fibrous tissue in the background than a conventional lipoma. A de-differentiated, as we talked about before, will have a typical liposarcoma appearance with focal areas of dedifferentiated high-grade spindle cells juxtaposed to a low-grade fatty tumor. So here's an example of a conventional liposarcoma where you have these mixed mature adipocytes with multiple lipoblasts. You have pycnotic nuclei, especially in the center and down in the bottom left there. You have significant pleomorphism of the nuclei, and then you have that fishnet background with some of that fibrous tissue interspersed between the cells. Here's an example of a dedifferentiated liposarcoma where you have the low-grade, almost lipoma appearance on the right side of the screen there with all of the mature adipocytes, and then on the left side you have the high-grade hypercellular spindle cell neoplasm. The myxoid subtype will have a significant amount of myxoid stroma in the background where you can see that relatively hypocellular background matrix with the interspersed adipocytes as well as lipoblasts. This will have a characteristic translocation of 1216 on FISH analysis with the FUS-CHOP gene fusion, which is pathognomonic for this tumor. And as we mentioned before, what's special about this is it tends to be very radiosensitive, and it often has bizarre sites of metastasis such as the retroperitoneum. Pleomorphic liposarcoma is usually a very high-grade, very hypercellular tumor, so you can see the background looks somewhat similar to the myxoid liposarcoma, but this is far more cellular than a typical myxoid liposarcoma. There's also a lot more pycnosis here and pleomorphism. Additionally, if you ran a FISH analysis on this, it will not exhibit the 1216 translocation. Now we'll move on to Leiomyosarcoma. This tends to again be middle to older age adults with a slight predilection to females over males. This represents 24% of all soft tissue sarcomas. Generally, these particular tumors do not occur in children, and if they do, they are often associated with Epstein-Barr virus and or an immunocompromised state, as well as a possible tumor syndrome like Li-Fraumeni. These are often superficial of fascia and can even be cutaneous, but if they're deep, they tend to be along major neurovascular bundles arising from the smooth muscle envelope around the vessels. The uterus is the most common site to find these, followed by the retroperitoneum, followed by the extremities. The lower extremity is the most common site when it is in the extremities, and 1/3 of them arise from veins. Often you'll need to sacrifice the involved segment of the vessels, so you often need a bypass graft or reanastomosis by vascular surgery if it involves a vital structure to the limb, such as the popliteal vessels. These also can have some bizarre sites of metastatic spread, usually to highly vascular areas. Like other soft tissue sarcomas, they do go to the lung most commonly, but they can also go to the liver and cutaneous metastases, including the scalp, where there's areas of hypervascularity compared to other regions of the skin. Prognosis of this tumor, unlike other sarcomas, depends more on the presence of microvascular invasion under the microscope as opposed to grade. So a low-grade leiomyosarcoma with microvascular invasion has worse prognosis than a high-grade leiomyosarcoma without it. 5-year survival also depends on location somewhat, where the subcutaneous tumors tend to have excellent survival with 83% at 5 years and 74% at 10 years, whereas the deeper tumors or retroperitoneal have a much worse prognosis with a 50% 5-year survival or 39% at 10 years. On histology, these will be the long, slender, cigar-shaped cells with a nucleus in the mid-portion of the cell and eosinophilic cytoplasm arranged in fascicles with individual cells parallel to each other. These will have the sarcoma stain, which is vimentin, which is essentially a marker of mesenchymal tissue origin. And then it will have smooth muscle markers such as desmin, smooth muscle actin, and H-cal-desmin immunohistochemical staining. Here's a close-up example of a leiomyosarcoma, again with those long, slender, cigar-shaped nuclei arranged in parallel fascicles with the densely eosinophilic cytoplasm surrounding it. And you can see in the bottom left as well as the top left, there are multiple mitotic figures, including bizarre mitoses. Synovial cell sarcoma tends to be a soft tissue sarcoma that involves younger adults, usually between the age of 20 and 40. It is more common in males than females, and it's the most common soft tissue sarcoma in the foot. Quite often, these are found in close proximity to, but not actually in joints, usually within 5 centimeters of a joint, which leaves the moniker of synovial cell sarcoma somewhat misleading. It actually has nothing to do with synovium or the joint. It has to do with the Latin meaning with egg, because the cells look like fried eggs. Imaging may show calcifications on up to 30% of these on x-rays. This is one of the more common soft tissue sarcomas to calcify. An MRI will be markedly heterogeneous with either this triple density sign or bowl of grape sign due to hemorrhage and fluid levels because these tend to be so aggressive. They tend to be dark on T1 and bright on T2, which is very characteristic for most soft tissue sarcomas. In terms of the histology, you can have a monophasic or a biphasic synovial cell sarcoma. The biphasic portion has epithelial cells in glandular formations with fibrous spindle cells interposed between those glands. The monophasic has the spindle cell component only without the glandular formation. These will have a very characteristic X18 translocation with the fusion of the SYT and either SSX1 or the SSX2 genes. There's a slightly better prognosis seen when the SSX2 gene is involved. These tend to always be high-grade lesions, and they can be cytokeratin antigen positive as well as CD99 positive. Here's an example of the biphasic one where you have these epithelial cells with the glandular formation and almost with some mucin within those glands with this interspersed spindle cell background between those pseudogland formations. A fibrosarcoma is a soft tissue sarcoma composed of malignant fibroblasts. It tends to be a disease of middle-aged adults or older age and a little bit more common in males over females. There's also a rare infantile variant that's present at birth or shortly after, but tends to have a good prognosis. These can also arise secondary to a Dermatofibrosarcoma Protuberans, where they do tend to metastasize readily and have a much worse prognosis than the typical DFSP would. These have a predilection for the thigh like other soft tissue sarcomas, as well as the lower leg, followed by the arms, followed by the trunk. These usually present as a painless mass as opposed to synovial sarcoma, which tends to be a very painful mass. This will demonstrate malignant fibroblasts that manifest as spindle cells in a herringbone pattern with hyperchromatic nuclei or pycnosis, variable collagen formation, and basophilic cytoplasm with rare mitoses. There's a low-grade fibromyxoid sarcoma, which is a variant of this, or LGFMS, which is strongly FUS, P21 and P27 positive, and weakly MIB1 cyclin E positive, which distinguishes this from myxofibrosarcoma because histologically they can look very similar. This also has a characteristic translocation of 716 with the FUS and CREB3L2 fusion gene. You can also see a translocation 1116 with the FUS and CREB3L1 fusion genes. Here's an example of that fibrosarcoma where you have that herringbone pattern where it almost looks like you have these sweeping fascicles going back and forth, left to right on this as you climb, and you also have those large blood vessels feeding this. Again, you see a lot of dark nuclei scattered throughout here and some pleomorphism, but scant obvious mitoses. Here's a close-up version where once again you see these parallel spindle cell nuclei with lots of fibrous tissue running between. Again, this could be confused with any of the sarcomas that we've seen so far, so again, why the immunohistochemical staining as well as the genetic analysis is key to getting this diagnosis. Undifferentiated pleomorphic sarcomas are the second most common extremity soft tissue sarcoma in adults to liposarcoma. It tends to be middle to older age adults and males more commonly than female. Again, the thigh is the most common site, followed by the lower leg, arm, forearm, and retroperitoneum. MRI, just like all of the other soft tissue sarcomas, will show a heterogeneous mass with significant intralesional enhancement with low signal intensity on the T1 and bright on the T2. These will show a characteristic undifferentiated pleomorphic spindle cells in a storiform or whorling pattern. The descriptor that I've heard for this is a helicopter landing in a wheat field with scattered histiocytic cells and hyalinized collagen bundles, which is why once upon a time this was called a malignant fibrous histiocytoma, but that name is no longer used. It will have the sarcoma stain or vimentin positive, indicating that it's a mesenchymal tissue origin, but otherwise it stains for almost nothing, which is why we don't know the lineage of this particular tumor. There are now several subtypes of this, including undifferentiated pleomorphic sarcoma, undifferentiated spindle cell sarcoma, undifferentiated epithelial sarcoma, and undifferentiated small cell sarcoma. Here is that storiform pattern or helicopter landing in a wheat field with this whorling pattern of these highly pleomorphic and anaplastic spindle cells. Here's a close-up image that shows how pleomorphic these are with all of these bizarre cells and bizarre mitoses. Not one nuclei looks like the next. Epithelioid sarcoma is the most common soft tissue sarcoma in the hand. It tends to present in the second or third decade of life, so again, a relatively younger diagnosis. Presentation is usually a subcutaneous mass or even a non-healing ulcer, almost presenting like a squamous cell carcinoma. They tend to be slow growing, but they have a very high rate of metastases as well as local recurrence and an exceptional lymph node propensity for metastases. And often that can even occur late. So the typical course for this is resection, local recurrence, amputation, metastases to local lymph nodes, higher level amputation, and so on until the patient finally succumbs to the disease. Because it's so common and so risky, there's now a lot of debate on if all of these patients should have a sentinel lymph node biopsy at the time of resection or use of a PET for staging as well as following. There's an unknown benefit versus side effect profile for chemo and radiation as well with this particular tumor, given its propensity to metastasize. Males, a tumor greater than 2 centimeters in size and a more proximal location in the extremity are all correlated with a worse outcome. Histology will show nodules of epithelial-appearing cells well blended with strong eosinophilic fusiform cells, many containing intracytoplasmic vacuoles with central necrosis. It tends to be vimentin positive once again, and S100 negative, which differentiates it from a nerve sheath tumor. It will be endothelial markers negative, which differentiate it from angiosarcoma. It will be P63 negative, which differentiates it from squamous cell carcinomas because histologically, morphologically, this can look like any of those tumors. So here it is. You can see these are much larger and plumper and rounder cells, which is why it's called the epithelioid sarcoma, but because it's vimentin positive, it gets classified as a sarcoma rather than carcinoma, even though it's often epithelial membrane antigen positive as well. You can see that mitotic figure in the low central right side of the image, as well as some pleomorphism amongst the nuclei present. Dermatofibrosarcoma protuberans tends to be a cutaneous and slow-growing low to intermediate grade malignancy, often involves the dermis as well as subdermis. It can be locally aggressive, but it has a very low rate of metastasis. However, as we mentioned earlier, it can progress or dedifferentiate into a frank fibrosarcoma or undifferentiated pleomorphic sarcoma that then can readily metastasize. Bednar's tumor is a DFSP with melanin pigmented dendritic cells that stain positive for S100. Epidemiology, this really can occur in almost any age, and in here it mentions 20 to 40-year-olds, and that certainly is common, but I've seen this in patients in their 80s and 90s. It tends to occur in darker skinned people at a greater propensity than light skin, and again, the thigh is the most common site. One of the big problems with this, as you can see, is it tends to have this infiltrative growth pattern that if it is resected and all that skin has to come out, flap and graft coverage tends to be a very common surgical outcome for these patients. Histology will show a prominent storiform pattern of monomorphic fibroblast-like cells that invade into subcutaneous tissues, very similar morphologically to an undifferentiated pleomorphic sarcoma. They are CD34 positive, which is an endothelial and mesenchymal marker. They have a characteristic translocation 1722 with the collagen 1A1 and PDGF beta fusion protein. Treatment, as we mentioned before, is usually wide resection alone. You may not even need radiation because they're low grade, depending on the margins and the exact location. And if the patient is very elderly or infirmed, because they're so low grade and they take a very long time to metastasize, sometimes you can simply observe these and not have to treat them and just watch out for the fibrosarcomatous dedifferentiation. Flap and graft is often needed, as we mentioned before, and these can be removed via Mohs surgery if they're small enough and no flap is anticipated. Here again is that example where you see that storiform pattern up top and a zoomed in image down below with the spindle cells in the storiform pattern with significant pleomorphism. Again, it looks like many of the sarcomas we've already looked at, so the translocation analysis and the immunohistochemical staining is what will get this diagnosis. Neurosarcoma, or malignant peripheral nerve sheath tumor, is the next soft tissue sarcoma we'll talk about. 50% of all of these occur in neurofibromatosis type 1 patients or von Recklinghausen disease. 5% of neurofibroma type 1 patients will develop this, and usually after a 20-plus year latency period arising in a neurofibroma, usually the plexiform subtype. It tends to be younger to middle-aged adults, and the brachial plexus is involved more often than the lumbosacral plexus, and major nerve trunks, especially the sciatic nerve. Histology will show hyperchromatic spindle cells in a herringbone or storiform pattern. They'll be S100 positive, which is what differentiates it from a fibrosarcoma. It will be Lu7 and myelin protein positive, but these are somewhat less reliable, but this is what helps differentiate it from DFSP and all of the other ones that can look like this as well. Angiosarcoma is a very rare soft tissue sarcoma that tends to be very aggressive and has a poor prognosis. Presentation, they may have a history of chronic stasis and lymphedema where this arises, or the presence of a previous lymph node resection. It's unknown why exactly, but the theory is that there's decreased clearance of toxic metabolites when the lymph nodes and the lymphatic system is not working properly, which may lead to increased tumorigenesis. These can be painful, they can ulcerate and fungate, and they can have significant mass effect, especially when they occur distally in the extremities where they can compress structures. These can metastasize to lymph nodes, and about 60% of these are cutaneous. You can see these also in the presence of a history of prolonged industrial or chemical exposure to vinyl chloride or PVC, thorotrast, or arsenic, so depending on where or how the patient works or what environment they're around. Stewart-Treves syndrome is angiosarcoma in the setting of chronic edema. 90% of these occur in women that previously underwent mastectomy with lymph node dissection. And what they will be is eccentric purplish lesions superimposed on brawny, non-pitting edema that may progress to large palpable nodules with ulceration and weepy discharge. On imaging, these will be low on T1 and bright signal on T2, just like every other soft tissue sarcoma. There will be dermal thickening and irregularity if they're cutaneous, such as the MRI there on the right side, where you can see that disruption and thickening of the skin. Histology will show abundant small blood vessels lined by large atypical endothelial cells with mitoses, including some atypical mitotic forms. Factor VIII associated antigen, CD31 and CD34 will all be positive, which are all endothelial markers. So here's a low power micrograph where you can see all of these very large vascular channels lined by endothelium with significant hypercellularity. As we zoom in, you can see how pleomorphic it is with lots of mitotic figures, pycnosis, pleomorphism, anaplasia, but again, significant vascular channels with these plump, more epithelial-like cells than the typical spindle cells we've been looking at. Clear cell sarcoma tends to be a sarcoma of younger adults, and it can commonly metastasize to bone and lymph nodes, and it is part of that race mnemonic. It's most commonly a painless mass arising in the distal extremities, especially the feet and ankles, but technically can occur anywhere. They're often fixed to tendons and aponeuroses, and they tend to have a poor prognosis. They are locally aggressive with high rates of metastases and recurrence similar to epithelioid sarcoma. On imaging, they tend to be relatively homogeneous compared to other soft tissue sarcomas, although not always the case. They're slightly hyperintense to skeletal muscle on T1, like you can see in A on the right there, but they're very hyperintense with significant gadolinium enhancement post-contrast, like you can see in B on the right. Necrosis and bony destruction are rare, and so you may underestimate the malignant potential of these prior to biopsy. Histology will demonstrate a fascicular growth pattern of spindle or polygonal cells. Cytoplasm is either clear or eosinophilic, and bundles of cells are outlined by eosinophilic fibrous septae. This has a characteristic translocation 1222 with the EWSR1 and ATF1 gene fusion, the same gene involved with Ewing sarcoma. These are also positive for melanoma markers S100, HMB45, and melin A, although melanin staining is not always observed. It's unknown if these are related, and they may have pre-melanosomes on histology. There was a study out of Utah a couple years ago too that took satellite cells within muscles, and by manipulating their genes can actually shunt them down a pathway that forms clear cell sarcoma or down a pathway that forms melanoma. And so the thought is that it's a satellite cell in a muscle that goes wrong that creates this tumor, and it follows a pathway that closely approximates melanoma, but then jumps off that pathway at a different time. So here is that example again with the clear cells. So you see all of the white background surrounding all of the nuclei. There is a little bit of eosinophilic cytoplasm, as you can see, but the majority of it is clear compared to what we've been seeing on the other more epithelioid-like tumors. Kaposi sarcoma is a cancer of lymphatic endothelium. It can have cutaneous or central involvement. Classically, it affects elderly people of Mediterranean, African, or Jewish descent, and it's now now considered an AIDS-defining illness in the presence of immunosuppression. There can be single or multiple papular red to black nodules, usually on the skin, oral mucosa, and the GI or respiratory tracts, but again, this can even occur in central organs. It can spread via lymph nodes. You can have local regional lymphadenopathy, and it's caused by a human herpes virus or HHV8. Imaging is usually not required other than staging, which involves a CT scan of the chest, abdomen, and pelvis. Histologically, it's highly vascular. It's a spindle cell lesion with occasionally intracellular hyaline protein globs, which are the arrows on the next slide, and it contains abnormally dense and irregular blood vessels, which is what gives it the characteristic dark color macroscopically. Treatment depends on where it's located. It can be cryotherapy, intralesional injections of vinblastine, alloretinoin gel, radiotherapy, topical immunotherapy with imiquimod, or surgical excision for localized cutaneous disease. Usually the deeper or the organ involvement will require resection. Extensive cutaneous disease or internal disease also will require IV chemotherapy and immunotherapy. Some patients will exhibit complete resolution of these just with management of AIDS if that's where this is occurring in the setting of. So here you can see those spindle cells with lots of red blood cells from the vascular channels that give it the dark color. And you can see the black arrow on the left side of the screen and the right side pointing to the large intracellular hyaline protein glob, or that pinkish eosinophilic homogeneous intracellular protein. One last thing in terms of soft tissue masses, I'll leave you with a clinical pearl, which again isn't hard and fast, but it's a general rule that can help you form a differential diagnosis when you see it. When you see an extremity tumor with multiple discrete lesions that involve soft tissue alone or both soft tissue and bone, think of a vascular lesion. If it's bone alone, it could be lots of other stuff, including benign entities. And so in terms of those vascular lesions, when you see multiple lesions involving multiple planes of tissue, think hemangiomatosis, Maffucci syndrome with hemangiomatosis, a fava lesion or fibroadipose vascular anomaly, skeletal angiomatosis, baxillary angiomatosis, Klippel-Trenaunay-Weber syndrome, and on the malignant side of things, Kaposi sarcoma, epithelioid hemangioendothelioma, and pseudomyogenic hemangioendothelioma. So here's an example of what I'm talking about, where on the x-ray there you have multiple lytic punched out lesions in the bone, where again we talked about if it's just bone involvement, well, that could be multiple myeloma, could be multiple other things. But when you get an MRI here, you see those lesions in the bone where those arrows are pointing to the hyperintense signal, but then you see these lesions out in the soft tissue too with the arrow pointing there, and this was a patient that had a pseudomyogenic hemangioendothelioma. In terms of non-vascular things that can cause this, neurofibromatosis, Langerhans cell histiocytosis, Erdheim-Chester disease are other things in the differential. So again, that's why it's not necessarily hard and fast, but things that can make you think. So that's it for the malignant soft tissue tumors. Thanks for listening. And with that, I'll leave you with my Pacific Northwest Pride slide. This is a view of the bridge from Oregon to Washington in Astoria, Oregon. And many of you might recognize this as a common sight seen in a lot of movies from the 80s, including The Goonies, Short Circuit, and Kindergarten Cop. It's a great place to visit, and there's a lot of really good breweries there if you ever get the time.